Hi, everybody. Looks like everyone is being let in. We're going to give everyone a little bit of time to jump on. Looks like there are quite a few of you here, which is lovely. All right. All right, so we'll give it a couple of minutes. Before we get started, I'll say all of this again, but just as we go, if you have questions, the chat is open. Either one of us who is presenting or we'll either weave it into what we're talking about or come back to the questions at the end of today. Looks like we have quite a few people here, so maybe we'll give it a minute and then get going. All right. Sometimes people have a little bit of a hard time. All right, looks like there's like nearing 30 people here, so maybe we'll go ahead and get started. What do you guys think? And it's going up. Okay. Hi, everybody. I am Eleanor Ezell. I'm an LCSW and I'm located in Nashville, Tennessee. I have a private practice here called Child and Family Therapy Collective. We obviously do a lot of SM work. I'm on the board of directors at Selective Mutism Association, and I'm here with two of my dear colleagues to present with you guys on ADHD and anxiety and understanding similarities and differences between them. So Rupal, do you want to go ahead and introduce yourself?
Yes, thanks, Eleanor. I'm Dr. Rupal Upadhyay. I am a pediatrician in the Chicagoland area. I'm with a private practice, Associates in Pediatrics, and I have been in practice for 18 years now. And I got involved with Selective Mutism Association because my youngest daughter was diagnosed with SM when she was 5. And so I have had the pleasure of being on the receiving end of a lot of the resources that are there, and over time have helped, become part of the organization. And now I'm also on the board of directors. So I love the work I do. And I do see a lot of patients with ADHD and anxiety as well. So we'll be giving you my perspective there.
Brittany?
Hello, everyone. My name is Dr. Brittany Bice-Urbach. I am a clinical psychologist in Milwaukee, Wisconsin. I work at Children's Wisconsin and am an associate professor at the Medical College of Wisconsin as well. I run the Selective Mutism and Anxiety programming at the Child Development Center here at Children's Wisconsin, and also am an evaluator or on our evaluation team for school performance concerns. So we see a lot of children for evaluation for various concerns, including ADHD, anxiety, and often that differential diagnosis. So glad to be here. I'm also a board member of the Selective Mutism Association, and so excited to be here with you tonight.
It's really fun for us to all get to present together because we don't get to do it very often, especially crossing our training lines. So it's very fun for us. Thank you guys for being here. And we have Kristen Leos, who's on our board as well. If you guys have questions, administrative questions, she will be able to help you out in the chat and after. Anyway, let's jump on in. Of course, we're gonna really dive into ADHD and anxiety today. This webinar is made possible thanks to the generous grant of the Gordon and Marilyn Macklin Foundation. So we're very grateful to them for supporting our work at SMA. They've really made a lot of things accessible to all of you for free, and that makes us very excited so we can continue to disseminate and get really good information out there. So today we're going to cover a lot in a pretty quick amount of time, just under an hour about. But what we're really going to go into is differentiating anxiety from ADHD. So we're going to start out by defining what ADHD is and looking at the similarities and differences between ADHD and anxiety, and particularly selective mutism. as you might expect, there are quite a few overlapping symptoms. And so one thing that we'll talk about is the function of behavior and like why a behavior is happening. So we'll dig into that. And then we're also going to look at how you can support ADHD symptoms in school, home, and from a medical perspective, and look at resources. So you guys may be here for many different reasons, but we hope that this is helpful for you. And I imagine that you guys will have questions. You are here for a reason, so I imagine you will. So if you would, just throw your questions in the chat. We will weave in answers as we can, and if we can't get to it, we'll come back to it at the end. I just want to remind everyone that we cannot give you specific clinical advice based on your particular kid, because for a couple of reasons. One, we're not your clinician, and two, we don't know everything that we would need to know to be able to give you a full comprehensive answer via a chat box. I wish it were that easy, but it's not. And so if we are generalizing answers, that's why we want to make sure that we're not misspeaking and giving you the access to the best resources that you have in your local area that best serve you. And sometimes giving answers that are too specific really doesn't actually help you. So we're always happy to, of course, link you up with additional resources outside of the presentation if that is needed. Let's go ahead and jump in. Rupal, I think you are going to start us off, yes?
Yes. So here we go. We're going to start first, obviously differentiating ADHD and anxiety. So if you want to go to the next slide, we're going to talk about what is ADHD. So ADHD is obviously known for the attention deficit hyperactivity disorder. It doesn't mean kids have both components. They may only have the difficulty focusing with the inattention, or they may have the hyperactive piece of it. But ultimately, it is a neurodevelopmental disorder. And it does include difficulty in all of these components. For some, it's, a little bit more of the attention issue. Some, it's more of the hyperactivity. And in some kids, we see the impulsiveness. It is a chronic condition. And oftentimes we can see the symptoms beginning as early as childhood. And for many people, they do persist even into adulthood. A lot of older adults, now I think we are fortunate. We're in an age where it is more prevalent. It's more acceptable to talk about it and get evaluated. But I have a lot of older friends and adults that now are getting diagnosed as adults with ADHD because it wasn't as common. It wasn't as well known even by clinicians when they were younger. So we're seeing even a lot of new diagnoses amongst adults or older adolescents and young adults nowadays as well. Okay, can go ahead and flip that slide. So I wanted to just give you some statistics of what the prevalence looks like. Currently, we'd say probably a little over 8% of children are estimated to have ADHD. We do see it in about 2.5% of adults. It's probably still prevalent in adults, but by the time they reach adulthood, whether they've been treated with medication or they've just received tools through therapy, many adults have now learned how to utilize some of those things that they struggled with as kids and sort of incorporated them into being able to be beneficial. Some of them go into vocations where it actually helps them, so they're better able to control those symptoms. We do see boys typically are diagnosed more with the hyperactive subtype, whereas with girls, we do see more commonly the inattentive subtype. And there are some risk factors, so if there is a strong family history, and this is true of a lot of underlying mental health disorders like anxiety and depression, but as well as ADHD, if there is a family history, there is a higher likelihood that children can be affected if one of the parents was diagnosed or thinks that they have ADHD. And then there is an increased risk in preemies. So a lot of our premature children will often experience developmental delays as well as neurodevelopmental delays, which can include things like ADHD. So oftentimes we do see these as some risk factors.
Hold on, it's not working. There it goes.
That's okay. Yeah. So the symptoms of ADHD, and I wanted to give you, obviously, these are the three big ones, the inattention, the hyperactivity, and the impulsivity. Wanted to give you some specific examples of what this might look like. Some of them are obvious. The inattention, obviously, not being able to pay attention to details, a lot of times making very careless mistakes. Some kids struggle with being able to complete tasks or activities, especially if they have multiple instructions involved. Many of these kids are really poor listeners. They are not able to not only listen, but also then struggle with following instruction. They have difficulty with that. They often have difficulty organizing or staying organized, and they struggle sometimes just with executive functioning because of that difficulty. And then many times they can be very forgetful. They easily lose things. So a lot of these types of symptoms fall under the inattentive component of ADHD. Hyperactive can look like children who are very squirmy or fidgety. They often need to continuously leave their seat, especially in a school setting. They can't stay seated for very long. Oftentimes they'll like run or climb, particularly in an inappropriate environment where it can actually be unsafe. Sometimes they have a hard time just relaxing, even doing leisurely activities. They have a hard time just being able to sit and enjoy an activity that's supposed to be relaxing. Always kind of on the go. And then the impulsivity piece of it kind of goes along with that. Many times they can talk excessively. They blurt out, oftentimes in school settings, blurt out answers. They interrupt. They often have trouble waiting their turn, whether it's in school or playing games. And those would all be signs of impulsivity. So I wanted to kind of give you the official, what we refer to as DSM-5 criteria. And these are the diagnostic criteria that a clinician would look for in your child before they can officially say that they have ADHD. And so you would usually expect to see this pattern of either the inattention, the hyperactivity, the impulsivity, and it has to be there for over 6 months. And it has to really interfere with their functioning or their development in at least 6 or more of the symptoms that we described earlier. So it has to you have to have at least 6 symptoms for over 6 months, and they have to interfere with day-to-day functioning. These symptoms do have to be present before 12 years of age. And for most kids, when I see them, they start to think about getting assessed or evaluated right as they get to be school age. So many of these kids, the parents will say, yeah, he was like this even as a toddler or as a young child, but you chalk it up to them being young, which very much is true. Sometimes you have to kind of wait it out a little bit to see if it persists. But the symptoms do typically start to present at a young age. The big thing, letter C, is very important as part of the criteria. And I'll mention why in a minute. But these symptoms have to occur in at least 2 settings. And usually for most kids, that's going to be at home or at school. Obviously, for our older adolescents or young adults, it may be more home or work, but they have to occur in at least 2 settings. And then we talked a little bit, that they interfere with that day-to-day functioning. And then, of course, you want to make sure that you've excluded any other mental disorders. And we'll talk a little bit about that because there are, as we are going to talk about, overlap with some other disorders that can look very similar. The reason, going back to see why it's important for that piece to be there is that oftentimes if these symptoms are only happening, for example, at school, but not at home, then it could be indicative that maybe there's a learning disorder that's going on, and it's not necessarily ADHD, but that's why the child is struggling. Versus if, let's say, these symptoms are happening only at home, but there's no complaints at school, and the child is doing perfectly fine, even academically at school, then it could be more of a behavioral issue or a developmental issue that's happening, that's being triggered at home. So it's really important that all of these criteria are met before we officially label this child with a diagnosis of ADHD. Next slide. So just to kind of give you an idea of how this assessment looks, and this is really more kind of from my perspective as a pediatrician, we're going to have a few other ideas that are going to be presented about how clinicians, and particularly at the school, they may use different scales. In our office, in our clinic, if I have a child that's, being brought to me to be assessed, usually it will be one of the top two scales, the Vanderbilt or the Connors. We used to use the Connors for years, and in the last probably 5 to 10 years, we've switched over to the Vanderbilt. It's an easier scale. We found that the teachers are a little bit more familiar with it, so it's easier for parents to have that filled out. And these are basically questionnaires that the parents fill out. We usually have each parent or guardian fill them out. If it's not a two-parent household, we say, if there's a grandparent or another caretaker that knows that child like a parent or plays a parental role, that would be a very important person to get feedback from. And then I usually want at least one teacher. The more, the better, because it really gives us a little bit more insight on where the child is struggling. So these are basically questionnaires that then get scored, and based on the scoring, then we kind of determine if that child meets the official criteria for ADHD. So let's talk a little bit. So comorbidity is a fancy word that really is to describe coexisting conditions that are common with certain diagnoses. So all the ones that are listed here can oftentimes be confused or misdiagnosed even, but often will have the same symptoms as ADHD. So it's really important when a child is getting an assessment that we look at all the different components. A lot of times the very first thing that I'll assess for, especially in a younger child, if they're having difficulty following instructions or being able to complete tasks, you want to make sure that they don't have a hearing impairment, especially if there's a delay in their language. So, right off the bat, that's one of the first things that we'll do, and we involve a lot of our speech therapists in helping with that assessment. We talked a little bit about a learning disability, and so learning disability can often look the same way. And once a child is at school age, it can be very frustrating. And if they're struggling because of a learning disability, then you may find that they are not able to stay focused, that they do act out, and then the behaviors can look very similar to some of the ADHD type of behaviors. The oppositional defiant disorder is something that we also see. I'd say about 35% of kids who have ADHD may also experience ODD. That is something that usually we will help from our colleagues in psychiatry to guide us with a little bit of a different level of assessment to help evaluate for that. Anxiety is a big one. I'd say about 25% of children with ADHD will also have some kind of an anxiety disorder. And that one is really important because if there are both things going on, we sometimes have to figure out which one is hindering them more and which one do we want to start by addressing. Oftentimes, if we start to treat one and we didn't recognize that there is something else going on, as you start to treat one of the disorders, the symptoms of the other one may start to become much more obvious. But there is a really high correlation, about 25%, between anxiety and ADHD. And then, of course, about 18 to 20% of these kids will also have some kind of a mood disorder. And we don't know, is it the chicken or the egg? Is it that they have ADHD, they're aware and cognizant of those struggles, and then it leads to these types of feelings of sadness and frustration, or if it's independent of it, but there is also a fairly strong correlation between the two. So it is really important to make sure before we jump into any kind of treatment plan, if we are concerned that children have ADHD, we really want to make sure we've ruled out any of these other comorbidities as well.
Within that, thank you, Rupal, for all that wonderful information. Wanted to highlight that ruling out those comorbidities can be a very challenging thing to do because as we'll talk about today, there are a lot of symptom overlaps, as well as we know that things like symptoms of ADHD can lead to additional anxiety. So struggling to participate in certain activities can make you more anxious about going into them. Struggling socially with your peers because of ADHD can make you more anxious to engage socially with your peers. And similarly, the negative feedback, the corrective feedback that children with ADHD often receive from teachers or staff in schools, the data suggests at kind of a 3-to-1 ratio, negative to positive feedback can impact mood, certainly, if we're getting that consistent and frequent correction that we're not doing things properly. So that differential diagnosis can be muddied by a number of different things. Although there are some wonderful screeners and supports that can happen for more straightforward cases of ADHD, or if we're more clear that it is a mix of ADHD and anxiety, for those more complicated cases where we're not quite sure exactly what's going on, additional assessment may be a valuable support. I put here, when we're thinking about assessment, you may hear a lot of different terms. There are lots of different terms that get used: psychological assessment, psychoeducational assessment, neuropsychological assessment, and largely these terms can be used interchangeably. There's different definitions depending on exactly who is defining these different terms. But what I like to think of these are comprehensive assessments, an assessment that's going to look more comprehensively across a variety of areas of functioning to better understand what might be going on for your child. Some of the areas that may be examined within those more comprehensive evaluations would include cognitive functioning, so a child's overall ability to think and learn and reason and problem solve. Recognizing that if we think about attention, a child who maybe struggles cognitively or is behind their chronological age and their thinking abilities likely will present as more inattentive, more impulsive, more distractible, but it's due to functioning at a younger age range and not at their chronological age. Looking at cognitive functioning for a child who is potentially going to receive a diagnosis of ADHD is also valuable because we know that there are specific areas of cognitive functioning that can be more challenging for children with ADHD. In particular, areas of cognitive proficiency, or kind of the speed and accuracy at which they can complete certain tasks. I put up these terms: working memory and processing speed. Those are two areas that not every child with ADHD will present with deficits in these areas, but we do see many children with ADHD struggle with working memory, the ability to hold on to information in order to follow through with tasks, as well as processing speed, the ability to quickly complete a simple and well-learned task. So the slower that we can go through those tasks, likely the more difficult it will be to follow through with them. Now, Rupal's rating scales that she included do look specifically at ADHD symptoms, and so those are often used within a comprehensive assessment. But there also may be more examination of executive functioning. Now, executive functioning, that is one's ability to plan, organize, and follow through. I always say it's what you do to follow through with the things you have to do, not necessarily the things you want to do. And so it includes a lot of different skills, including our ability to self-monitor, to self-regulate, and to plan and organize to follow through. Executive functioning skills can be looked at within comprehensive assessment through a variety of measures. I listed some out here. That this isn't a full comprehensive list. Some of these measures are meant to be things done with a child, and others are rating scales, similar to what Rupal spoke about already, that look at specific skills of executive functioning. Now, when we're doing that differential diagnosis, we know those social, emotional, or behavioral factors also should be examined. And so there are a number of measures that can be used to look at both, kind of at the broad sense, a variety of behaviors. So things like external behaviors, like oppositional behaviors that Rupal was speaking about, as well as internalizing behaviors like anxiety and depression. And so these first two, the behavior rating system for children and the Achenbach child behavior checklist and teacher report form, are both comprehensive measures that look across a variety of behaviors. Whereas I also included, there are some specific anxiety measures that can be used when we're concerned or questioning if anxiety might be present. And again, given that ADHD can impact learning, there are children that struggle with learning, not because of a learning disability, but the impacts of ADHD on learning. As well as we know there's a high overlap of children who struggle with learning disabilities and ADHD. Likely a comprehensive evaluation would also assess academic functioning, looking at a child's functioning as compared to their same age or grade level peers within reading, writing, and mathematics usually. Another evaluation that potentially may occur would be within a school setting. And so we'll talk a little bit more about school services and supports towards the end of the presentation, but just wanting to highlight that when an evaluation occurs in the school, they may do a number of these things like rating scales, executive functioning measures, ADHD measures, but their role is not to diagnose. So it's not a diagnostic evaluation. The information that they're gathering is meant to be more for determining qualification for further formal supports in a school setting, as well as treatment planning or helping to plan out what supports may be most valuable to that child within their support plans. So we'll talk more about that in a little bit.
All right. So we've talked a lot about ADHD and some of the things that how it can look, how it can present. All of you, if you guys are involved in SMA, you probably have an anxious kid. We love them, but anxiety is tricky. And especially if you are trying to figure out if your kid is struggling with ADHD as well. So I'm going to talk a little bit about differentiating ADHD from anxiety. About 4 to 10 kids with ADHD also will meet criteria for an anxiety disorder, which is, in my opinion, surprisingly high. It also makes a lot of sense. So there are a couple of things that I consider when I'm looking at a child with ADHD is, do they have anxiety? And also, is it coming after the ADHD symptoms or is it coming before? So what is happening first in their day? Are they waking up anxious or are they waking up without executive functioning? Because those all look very similar. And when you say that to a parent, sometimes they'll say, oh, they start their day with failure, right? They can't make up their bed. They can't listen to commands, right? And that is an important differentiation. So when we look at the disorders, both disorders, of course, are driven by changes in that prefrontal cortex right up here. But anxiety is driven by a fight or flight response, so fear. And those changes kind of come and go in the brain. And then ADHD is driven by more structural chemical differences, and that is much more constant. And so the function of that, 6 a.m. wake up dysfunction, if that first 30 minutes is absolutely chaotic, that it could be for a couple of different reasons. And as I said at the beginning, we want to make sure we're looking at the function, the reason why something is happening when we're diagnosing and looking at potential comorbid disorders. That's really, really, really important. If you hear nothing else, remember that. So when we're looking at anxiety, we've talked pretty extensively about ADHD. You have avoidance. If we look at this nice little image here, we have anxiety, we have avoidance, and then we have this like behavior dysregulation. This behavior dysregulation often looks like ADHD. It looks like, oh, they're just dysregulated, they didn't get it, they're just, they're having a tantrum, it can look defiant even, it can look like a child's choosing not to listen. It looks like a kid's fighting back. And this flight, that fight or flight, the avoidance, it's peace, I'm out, I'm running because this is too hard and my body thinks there's a tiger chasing me right now. So I'm out, I'm running out the door, I'm running away, or I'm gonna hide. You also can see that freeze response. But those anxiety symptoms, they're gonna sound repetitive as to what we've already said. You see inhibition. You see kids who are a little bit more reserved. Maybe they look like they don't know what to do. They might look lost. which also could look like inattention, which we'll talk about, avoidant to task. This is a really, really common symptom that you see in both. So kids who are anxious about starting something versus a child who is having a hard time starting. That can look identical for a different reason. Kids with anxiety can look shy, can be shy or nervous. They'll shut down, they'll stop talking in the SM world, or they'll kind of act like you're not there, like whatever you're prompting them to do is not real. They want to be near their things that make them feel more comfortable, their parents, their familiar items. And kids also can look really silly and dysregulated and distracted. They can fidget a lot when they're anxious, having temper tantrums, lashing out. So you see how both sides of this anxiety coin, one looks more traditionally anxious and one looks ADHD, oppositional, big air quotes here, if you're listening and you can't see me, because we call the difference like internalizing anxiety. So it's more inside, or externalizing anxiety, more outside. It's more outward in what it looks like in terms of what the behaviors are. And that is really important information as we're looking at the function, the reason behind why something is happening for a particular child. And so when we think about ADHD as well, you see that list on the right there: silly, dysregulated, class clown. You get a lot of ADHD kids who are the class clown. Awesome kids, but they're hilarious, and it's kind of off timing, right? They fidget a lot, they're up and running, they're out of their seat, they want a standing desk, right? Maybe they're having some really big emotions. It can be quite confusing to figure out what's what if we're not getting that full view and of a child from all of the different domains that all three of us have already spoken about, right? So you need to get that full comprehensive evaluation. So teachers, caregivers, and the child, if they're old enough to give an accurate self-report about what it feels like.
With all that Eleanor was sharing, I think it's valuable to think about that symptom overlap. I know she started to present some wonderful details about how this symptom, or this thing that we can visibly see, may be driven by two very different things for ADHD and anxiety. And so here I have some common inattentive symptoms that we often see, things like distractibility, difficulty following directions, disorganization or inefficiency with completing work, difficulty with task completion. And again, if we look at for children with ADHD, we often see that those challenges, those inattentive symptoms, are likely to be a more consistent challenge for them. They're also likely due to kind of a mix of internal distractions, things that they think about and get kind of off topic and off track on, as well as external distractions. The child next to them who's doing something really interesting, or the dripping sound that they hear of the faucet in the room, or the lawnmower that's going off outside as they're trying to be doing something. And so all of those external and internal distractions may cause them to appear distracted. Whereas for a child with anxiety, we may see what appears to be distractibility, but often it's driven more by situations where they are experiencing discomfort or fear. So in those moments when they are presented with triggering events, that they may start to pull back and appear more distracted. And it's often either the internal stimuli of their worry, thinking about all of the potential worries that could happen that cause them to kind of not stay in the moment and present for what's happening around them, as well as it could be kind of the external stimulation of whatever the feared scenario is or situation is. As we think about that difficulty with following directions, we can see that for a child with ADHD, being inattentive or distracted and not attending to the information that's presented is going to make it much harder to follow through with the tasks and directions provided. We also know that it's very difficult for kiddos with ADHD to give kind of that extra effort to put into the things that are less preferred or seen as difficult or challenging. Whereas for a child with anxiety, it's often due to that worry or fear about how they will do in the task, or the distraction of internal stimuli of the worry of how they will do that makes it harder for them to follow through. So you'll see a theme here with many of these. I'll just pick one more, the difficulty completing tasks. Again, we see the distraction and that maybe lesser motivation for for completing tasks that are less preferred, being difficult for children with ADHD, whereas for anxiety, the difficulty completing may be more due to perfectionism, wanting to make sure it's perfect and maybe avoiding the task if they feel they can't do it in the exact way or the way they want. So we can see this variability. Same thing with those hyperactive and impulsive. So as Eleanor was mentioning, some of those things on that side of the screen for anxiety scream ADHD symptoms, increased movement, moments of dysregulation. However, when we think of a child with anxiety, the increased movement or fidgeting may be due to tenseness or nervous energy that they have. And this is a way to kind of let out some of that bottled up tension that they have inside. The moments of dysregulation, we can sometimes see that in a feared situation, a child may be more likely to go into that fight mode and react in yelling or anger or frustration. We also, for many children with anxiety, see that just the buildup of stress throughout a day can lead to bigger blow-ups or dysregulation in the evening time. So as their bucket kind of gets filled throughout the day with different stressors, sometimes it will be a very small thing that fills up the last part of the bucket and overflows the bucket into a moment of dysregulation. For children with selective mutism, although it's not as common of a presentation, we certainly do also see some children who may have moments of dysregulation due to some of the frustration of not feeling comfortable to share their words. And so they may use their actions or their behaviors, hitting or getting upset about something, as a way to express themselves, express how they're feeling, express the situation, and potentially also to avoid that uncomfortable setting or situation. So we've covered a lot of information about ADHD, anxiety, and the overlap between them as we're trying to consider a diagnosis. We want to switch gears a little bit and think now more about how do we support these symptoms at home and at school. Because this talk is primarily focused on ADHD, many of these things are going to be ADHD focused. However, I think it's also important to recognize that although there may be some adjustments and intervention, certainly for a child with anxiety, there are also some overlapping components that can be very valuable for kids who are experiencing difficulty with task completion, for example, just due to anxiety. So first, I wanted to start by thinking a little bit more about how we can support children in the school setting around these inattentive or hyperactive or impulsive symptoms that might be present. One thing I want to note, and this is such a challenge always when we do these larger talks nationally, because we know there's such variability in supports available and what supports look like from school to school, district to district, state to state. So when we're talking about these things, I am going to talk about them in a much broader sense. In general, from the broad sense, we know that there are supports that can be available to students who struggle with ADHD symptoms in school settings. And in particular, what Rupal was sharing about that functional impact. Children who receive support in the school setting, it's because the school is seeing a functional impact. It's impacting their classroom performance. It's impacting their ability to follow through with work tasks and things needed in the classroom. It may be impacting their social relationships with staff at school or peers at school. And it may also be potentially impacting their learning, that the inattention or distractibility or impulsivity of walking to the restroom every time they are feeling a little bored in class may make it harder to hold on to and learn information. And so there are additional supports available in school settings. One thing to note, in a private school setting, we don't have access to the same formal supports that we do here in the States for children in public school settings. However, in private school settings, a child can still be evaluated for services and supports. They just might not actually receive them if they remain in the private school. With that said, I will just note, many schools do provide access to support in a private school setting, and can do some wonderful interventions and accommodations in place, even if it's not legally binding that they do it. On the other side, when we think of the public school setting, there are some informal supports or kind of early intervention supports that many schools will offer to children who are struggling. There also are more formal accommodation supports through something like a Section 504 plan. And as we think about, so Section 504 is just going to be classroom accommodations. What we're saying there is those children will still be expected to meet all grade level criteria, do all grade level tasks. We might just give them an accommodation to help level the playing field so that they can better participate and show what they know. Whereas in an IEP, an individualized education plan, that will be, if a child qualifies for that type of support, that will be some modified expectations in areas where the child may struggle due to their disability. For that, if a child were to qualify, there will be goals that are set specific to their needs, as well as access to accommodations. And they will work with special education providers to help them continue to progress within their goal areas. I mentioned here OHI, other health impairment, is the most common that children with ADHD qualify for support in a school setting. As far as interventions that may take place in a school setting, there are a variety of different interventions. Some might be things like self-monitoring strategies. We know children with ADHD struggle to have awareness of how their actions may be impacting their functioning or their perception from others. And so many self-monitoring strategies are ways for the child to start to become more aware of when they're distracted, or if there are certain behaviors that are making it harder for them to follow through with tasks. Behavior management strategies are also things that may be put in place for children with ADHD, such as if children struggle to transition from one activity to another, a visual timer may help them to make that transition more smoothly. Pre-teaching and being very concrete in our instructions and expectations, so our kids with ADHD can follow through more accurately. We might use reinforcement or contingency management systems with our kids with ADHD. Check-in, check-out, or what's listed here as CICO, is a very common kind of early intervention support for children with ADHD and other behavioral concerns. And so here's just an example of a visual. There are general goals to be safe, respectful, and responsible. They get feedback on that throughout the day, and then they get a personal connection with someone to talk about how things are going. It also earns them some access to special rewards or reinforcers for getting higher numbers or better numbers on that. There are also things like token economy systems where they're able to earn points or prizes for properly following the expectations that they have, or sticker charts can all be used to help the child feel more positive and successful within the classroom setting. As we mentioned, social challenges can occur for some of our kids with ADHD, and so it's possible that children in the school setting can be a part of a social skills group, or an ADHD specific group where they will practice and learn new skills and strategies to help with some of those challenges. And also, we know the organization and planning for follow-through can be a very difficult thing for our kids with ADHD. And so there might be things like setting up more clear visual routines and schedules in the classroom, having opportunities to clean out your desk more regularly, or your backpack more regularly, or your locker more regularly, so that that organization is a little bit better. Using systems like folder systems or color coding systems to help with organization, or working with a child on using a daily planner or homework log to keep track of homework assignments can all be types of intervention strategies. And then if you want to move on, I also listed out just some common accommodations that we see for children with inattentive symptoms versus hyperactive impulsive. There's some overlap between these, but common things we'd see: preferential seating, where they're going to be seated potentially closer to the teacher or away from other distractions. Placement next to a positive peer model who might be able to model and demonstrate some of those behaviors that they get distracted and miss, and they can reference back to that peer. Breaking tasks into smaller steps and giving them more reinforcement along the way. Making sure we're being very concrete and clear with our instructions, so they're not misreading or misinterpreting what we're asking of them. Additional check-ins with the child, tests in separate locations with fewer distractions, more time to complete tasks, breaks during the day, limiting repetitive assignments where they feel like they're doing the same thing over and over and over again. Maybe they just get to do the odds or the evens. And also access to things like certain organizational tools or technology that might help them more efficiently follow through with things. Another one I like to mention here is the homeschool communication piece, so that families can be more aware of what's going on when assignments are due, when bigger projects are coming up, so that we don't get into a situation where the child is all of a sudden saying, it's due in 2 hours and I haven't started it. As far as the hyperactive impulsive symptoms, a few things to also mention: access to opportunities to move or fidget that could be at a desk, like a wobble chair or a band that goes onto the chair, access to fidgets that can be present on their desk. Also things like ignoring those minor misbehaviors that are happening and giving a lot of direct and labeled praise for the positive behaviors that are happening. In fact, we would say, let's give lots and lots of the positive praise and try to reduce the negative corrective feedback for these kids because of that 3-to-1 ratio I was talking about previously. And sometimes it's even something like a private signal from the teacher that's just kind of this is our way of saying, maybe we should kind of settle down and get started on our work because we're getting too distracted. And so just some accommodations that might be accessible and available.
I want to add one thing that I love that you said, Brittany. Obviously, a lot of these accommodations are really similar and different. One of the things that I find as a clinician to be the most helpful in finding the right accommodations, and you can use this when you go talk to your kid's school, is literally asking the teacher, which of these are you most likely to actually do? And which of these come most naturally to you? Because if it's on that IEP or on the accommodation, whichever format you have, and it doesn't cross the teacher's brain to do it, it's not going to work. And it's a little trick that I've started to do a long time ago now, but it really also gets really nice school home communication, and it respects the teacher's strengths really nicely. Teachers will say, I really thank you for asking me because I want to be successful for this child. And it really is this nice connector. So as we talk about home and school interventions, just think about, okay, so how can I build bridges here instead of telling someone you need to be doing this for my child, but how can you build bridges using their strengths already? It also will feel more authentic, and your child's far more likely to respond to something that feels authentic rather than it's, if it doesn't feel right to me, I'm just not going to do it. But I have to because it's an illegal document. It just feels icky. So just wanted to throw that in there as a trick that it has been helpful minimally for the relationship, more likely in like how it actually functions. With that said, of course, school interventions are really important, as are home interventions. And so all of those similar interventions that Brittany was discussing, the token economy, positive praise, structured home, clear expectations, clear definitions for what it means to complete a task. All of those things also need to happen at home. And when you're not a teacher and you're a parent of an ADHD child who's been keeping it together all day at school, this is really hard. But this is what we want to do. Have a nice, clear expectation about what it means to clean up the toys. That, in my opinion, is too broad, unless it has been defined as in a photo right next to the direction, clean up the toys, so the child knows exactly what the playroom looks like when it's done. Visuals, right, are going to be so incredibly helpful. They're going to help us set those clear, consistent limits and expectations far more than describing it to your child over 10 minutes. Just take the picture of the clean playroom. This is what it looks like when it's done. Make it batch. That's the direction. Helping our kids learn from their mistakes without shame is going to be really, really critical. Because if we are unintentionally putting shame and unintentionally saying, and truly parents do not mean to do this at all. If we say, hey, why did that happen today? Right? That's going to probably elicit some like, oh my, shame in our children. But instead we can say, hey, what happened and what did you notice? I'm happy to help you problem solve it. That is going to be more likely to elicit more problem solving in your child, and also more connection if it's done after you've had some positive time together, giving them lots of feedback, filling up their emotion cup, all of that time, all of that stuff, special time, CDI skills all day long. If you know what those are from PCA-TSM training, highly recommend just taking those CDI skills, use them with your ADHD child, and then just tailor them directly at home to exactly what you want them to do more of, right? Same thing with organizational and planning support. Instead of assuming that, oh, they're just going to follow me and get it. No, they're not. Not at all. You need to write it out and say, okay, so the example in my head, I did this today in therapy. A child's going to the airport tomorrow, was so incredibly chaotic about thinking about it. She was so stressed out because she couldn't plan. So what did we do? We wrote out first, Dad's going to drive the car. Your bags will be by the door tonight. We had her list. And so now she can go home tonight and check it off. And she said, whew, now that it's on paper and written out, I think I'm going to be totally fine. I'm not going to get anxious because I know what my plan is and I know how to do it. Right? Anxiety and ADHD, they collide. And so when we can have that organizational and planning support for what is expected and what may or may not happen, then that supplemental anxiety, as I like to call it, doesn't tag on. And then we actually can have our supports work more effectively. And it's beautiful when it works. Shockingly, it's quite calm when it works too. And of course, all of this is going to come with pretty extensive parent training. This is sort of a 101 here. But it is hard to do this, especially if you don't have an ADHD brain. It is really hard to master what your child needs, knowing that what they need right now and what they need in an hour might be completely different. And it's just about filling your toolbox so you can at least try something to help them so they're not getting so dysregulated. Sometimes it feels a little bit like roulette, like, I don't know what's going to work right now, but let me pull something out of my toolbox and try it. But, when you have a big toolbox, it's more likely to work because those tools are established in the child's body as well. They've done them many, many, many times. So I would actually also add on to this consistent practice using all of your tools. And it's not something that just like works when you do it once. No, you need to practice it and keep it alive, as I always say. Rupal, can you take over for meds? Also, I'm realizing how dark it's getting in here.
Yes, absolutely. And I want to be respectful of time and make sure we have enough left at the end for questions. So I'm going to just kind of touch very briefly on medication because I know that a lot of parents have questions about it. So I just want to really introduce you to the different types of medicines and some of the most common side effects, but more importantly, how they work and why they can be an important part of the treatment plan. One of the things to really keep in mind is that the treatment for ADHD, as well as for anxiety and a lot of our other mental health disorders, is always what we call or refer to as a multimodal approach. And the things that both Brittany and Eleanor spoke of, all of the supports from parent training, home support, school support, where our kids spend a majority of their day, those are going to be so critical and always are going to be recommended to go through first before we may consider medication as an adjunct to their therapy. So I always tell parents, this is an adjunct. This is not I wish there was a magical pill that we could give our kids and it'll fix them overnight. It doesn't work like that. These are going to, even for those kids that get to a point where they need medication, the other strategies, the other support systems are going to be very, very important. And in fact, once they start medication is when most kids, especially those kids with the anxiety and the SM, they've been learning a lot of these tools all along, and they're not able to utilize them until the medication helps them really be able to utilize those tools. So the two are intertwined and very much necessary in conjunction with the medication. So I just want to kind of put that disclaimer out there that these are not magical pills. I wish it were that simple. So the two kind of big categories of medication for the treatment of ADHD are the stimulants and the non-stimulants. I listed a couple of names just again to help you guys become familiar with the non-stimulants, Strattera, the guanfacine, or also known as Intuniv, and clonidine. I'm not going to spend too much time talking about the non-stimulants, primarily because stimulants are the first line of treatment for ADHD for a majority of my patients for several reasons. One is that they're just, much more affordable, I should say, or insurance tends to cover them. We don't want it to become about price, but unfortunately, they do have better access and coverage with stimulants. But more importantly, from a clinical perspective, they work very quickly. Usually within 7 to 10 days, we're going to start to see improvement in symptoms. So they work very quickly versus the non-stimulants, which I typically use for more of my older kids who may have been on stimulants early on. Those can take up to 6 to 8 weeks before you really see improvement. And sometimes are used not just for inattention and hyperactivity, but also behavioral symptoms. So sometimes you'll see Intuniv being used as an adjunct with a stimulant, but it's generally not used on its own, and certainly not necessarily as a first line. The other nice thing about the stimulants is the analogy I always make with my families when I'm explaining to them how they work is you want to think of it as a light switch. When the child gets the medication in the morning, it's like you're turning on their light switch. And then most of the stimulant medications these days are formulated as extended release. So they will slowly kind of be released into the system throughout the day. And by the end of the day, depending on which medicine and the duration of that medication, they start to sort of fade, and the light will fade when the time comes for bed. So oftentimes these medications can be used not in the beginning necessarily, but after you know which medicine and which dose works well for the child, you can take a holiday, So a lot of my patients will say, well, we're not super structured over the weekend. We're not going to take it. We only take it during, the 5 days of the school week. That's fine. We're not going to take it during summer break. We're not going to take it, when we go on holiday for winter or spring break. And that's perfectly fine to do. The problem is that a lot of our kids these days are very structured during the holidays and summer. So unfortunately, they may still need them, but they can be used that way. So I do like it for that reason. The thing I will bring to your attention, and most of you are probably aware, that stimulant medication is considered a Schedule II controlled substance. And excuse me, what the USDA does in labeling it as such is there is a potential for abuse and misuse. And so it is a highly regulated and controlled medication. It has to be prescribed by your physician. We are very, very particular about how many prescriptions we give to our patients, how many refills we give, because unfortunately there are sometimes occurrences where it is abused. However, it is not addictive. It is not something your child will become dependent on. There is no tolerance that builds over it. So when it's used safely and appropriately in a child where it's indicated, it is absolutely perfectly safe to use. The reason it's such a controlled substance and sometimes gets a bad rap is that it can be abused if that's what people are looking to do. Okay, if we move on to the next slide, I'm going to talk a little bit about how they work. So oftentimes families will ask, why am I giving a stimulant to a child that's already very hyper or very inattentive? I don't understand. It doesn't make sense. Well, what we're actually doing is we're changing a little bit of the chemistry of the brain, and not by introducing a new substance, but just by helping increase a substance that's already there. It's what we refer to as neurotransmitters, which are basically some of the hormones that circulate in our brain, particularly dopamine and norepinephrine. So what the stimulant medicine does is it stimulates our brain to produce a little bit more of that dopamine and norepinephrine. And you're probably familiar with dopamine being kind of the feel-good hormone. It helps us in feeling good. It helps us regulate a little bit better. It helps with impulse control. And it just creates a more balanced state of mind when it is a little bit higher. And for many of these kids, when studies have been done, it is found that their levels of dopamine and norepinephrine are a little bit lower than what they need to be. So you're really just helping bring their levels up to the place that they need to be. I'm going to piggyback on something that Eleanor had said earlier, because this relates just as much to medication as it does to a lot of the other therapeutic modalities that are used in children. The key thing to remember is that our frontal cortex, it continues to develop up until the age of 25. So we are not fully developed with our frontal cortex until that age. And what that means is when our children are receiving behavioral therapy, cognitive therapy, what this is doing is it's allowing their brain to develop in synchrony with positive reinforcement. And that positive reinforcement will actually create new connections in the brain and create positive associations with things that either they couldn't do before or were too afraid to do before. So for many children, and I know parents are very apprehensive, my child is only 9, my child is only 10, am I really going to start them on medicine? Well, a lot of, again, there's 2 or 3 really big studies that have been done in medication on children with particularly anxiety medication, but there's been many more studies on ADHD medicine. And what we find is that actually, if we start to treat a child who really does need it at a younger age, they're more likely to benefit from all the therapy that they're getting, because their brain is going to start to create those positive connections at a much earlier age as it's developing. And many of those kids then will no longer rely on medicine as they get older, because they have now created tools and systems that work for them, which is so important. So keep that in mind as if you're considering medicine. Yeah, absolutely.
So someone's asking about medication and stuff, and I just want to add this.
Yeah.
The way so I'm a behavioral clinician. I own a practice, and I see a lot of ADHD, a lot of SM, and honestly, a lot of it together. And the way I think about medicine as someone who does not prescribe it, there are a couple of things here. We say in my practice, kids deserve their childhood. Full stop. If a child doesn't have access to their childhood, they're coming to my office. Whether it's because they're so hyper or because they're so inhibited, whatever the reason, maybe it's social difficulties, whatever it is. So when I think about when I'm recommending a medication consult with a psychiatrist or a pediatrician, I think about, is the behavioral intervention giving them enough access where they feel like they're really living, right? I know that sounds silly, but like where they're able to go to the playground and play and not get in trouble and actually play. If that's happening through behavioral intervention, awesome. If it's not, and you're just looking at an SM kid, then and I'm doing like really good work, as hopefully I always am, and I've seen them for 6 weeks and I'm not seeing a difference, then we're having a medication conversation. I tell my patients this from day one, because their child does not have time, in my professional opinion, to not be able to learn how to advocate and use their voice. Same
Yeah.
goes for ADHD, right? So if an ADHD intervention, and someone was asking about what interventions are for ADHD, PCIT is a great one. If behavioral intervention is working, awesome. Let's stay on that as long as we can. But kids get older, and at about age 7, we flip-flop to meds and behavioral for kids. Because at age 6, after age 6, most of your brain is done developing. So we try to, in my opinion, we try to keep kids off any meds until age 7, 7th birthday, 6, 7. But I've seen kids as young as 4 on medications, and it is completely life-changing because it gives them access to their childhood, and it gives them the crutches. Like if your leg is broken and you're not going to be like, yeah, you don't need a wheelchair. Think about it like that. Right? If your kid's leg was broken, you're not going to be like, yeah, you're just going to, limp around. No, we would never. So if your kid is struggling so deeply that they're not able to be a kid ever, that's when I really would challenge the general rule of waiting till after age 6. Rupal, how do you feel about
Yeah,
that?
absolutely. So what I usually, the rule of thumb that I tell parents is that when you're working with a therapist, and especially consistently like that, getting good therapy, you're seeing gains and you're seeing the child meet some goals. I usually say it's safe to give it at least 6 to 12 weeks is kind of the rough ballpark that I'll say. If after 3 months of very intense, regular, good therapy practice at home, we've made gains, but we're hitting a roadblock that we just can't overcome, that's when that medication conversation definitely starts to play a role. I don't necessarily put a hard and fast age limit on it because, quite honestly, when there are comorbidities, we may see kids that are much younger than 7 that will need medication. Just real quick to speak anecdotally about my own daughter, who has selective mutism and had a really, pretty significant amount of social anxiety. We started her on medicine at age 7. And again, it's not always an easy thing to do, but it's life-changing for these kids because it's like you said, they want to do these things. They want to go to that birthday party, and it's so heartbreaking, and I've seen it as a parent, as much as I have as a physician. And these patients, it's just, you want to help support them however you can.
I'm going to edit one thing I said. Age 7 for a stimulant.
Oh, yeah.
Age 7 for a stimulant. And
Yes.
Anxiety medications are safe.
Correct. Yes. And
Totally.
part of the reason why age 7 makes sense for a stimulant is because, like we talked about at the very beginning, when we're looking at a lot of the symptoms of ADHD, it's often difficult to say, is this just a 6-year-old boy being a 6-year-old boy, or is there something more to it? And typically, as they get from those primary grade levels, 1st grade, they're moving on to 2nd, by 3rd grade, there's a little bit of a higher expectation. Academically, challenges are a little bit more. You will start to see those symptoms impacting their ability to function in school, and not necessarily academically. These are some of my brightest kids. They do great, but the problem is that it keeps them from being able to, complete things. So real quick, actually, Eleanor, if you don't mind going back to the slide with the medications, I just wanted to briefly touch on the type of stimulant medicines.
Hold on. This one? That one.
Yeah, this one. So within the stimulant category, there are 2 major types of stimulant medicines. The methylphenidate category, those are the ones we typically hear about, the Ritalin, the Focalin, Concerta, and those are going to vary on duration. So Ritalin is an excellent medicine, very old, but it's great, but it only has about 4 hours of duration. Focalin generally, which is the one that I tend to go to first, is about 6 to 8 hours. And then Concerta, which I do for some of my older kiddos who need longer duration of control, about 10 to 12 hours. The amphetamines are a different formulation of the stimulants. Those are more the Adderall, the Vyvanse, and again, little bit of different variants in side effects as well. And then real quick, I'll just touch on the side effects. I know we're really past our time, but I want to give enough time to this. So the most common side effects, the three biggest things that I always tell parents as we start the medicine, the first thing you'll notice is this, it's going to suppress their appetite. Stimulant medicines, in fact, have been studied to suppress appetite, so much so that a lot of our endocrinologists who treat older kids and adults actually use stimulant medicines as an appetite suppressant for people who are struggling with obesity and weight loss. So it is a definite known side effect. Now, here's why it can be used safely in those kids. Typically, the appetite suppression happens at the peak of when the medicine is going to be in their system, usually midday. So they may not eat their lunch. They may come home with their full lunch still intact. But as the medicine wears off, they will be famished and they will more than make up for the calories that they may not have had. So much so that as I follow these patients pretty closely over time, we do not see any kind of long-term effect on their growth or development because they've been on a stimulant medicine. So we know it's safe to use in that way. The other thing that you will see is that because initially it's going to be increasing that dopamine and the norepinephrine, a lot of these kiddos who already struggle with sleep are going to have even a harder time falling asleep. This one is an easier adjustment because oftentimes we can determine when we give the medicine, and if we know what the duration is going to be, we can adjust it. So for example, most kids will take it with breakfast, but if it's causing a lot of sleep disturbance and they're not falling asleep in a timely fashion, I'll tell parents, we'll wake them up maybe an hour before they're actually getting up, jostle them enough to sit up and take their meds, have them go back to sleep for an hour. And then the nice thing is the med's actually already kicking in. So the whole process of the morning routine is a whole lot easier too. So that's an easier one to fix. The social withdrawal, it's not so much social withdrawal as much as I see maybe like, I refer to it more as emotional lability. Like sometimes I see kids getting a little bit more emotional, all of a sudden crying out of the blue. And again, that has to do with that kind of chemical balance changes that we're going to see. The good news is that that is generally very transient, meaning that within a few weeks of their body sort of adjusting, you will see less and less of that. The good news is that even some of these more common and even the lesser common side effects are usually so minor compared to all the benefits that these children get from it that it's totally worthwhile. And again, no long-term effects on even growth or development in any way. So I think that was it. Yeah. And then we've got some resources. The AAP has excellent resources. And then we have a couple of resources, and these slides will be shared with you as well. So we can open it up if we have a little time.
Another one I was just going to note for families looking for parent training support, Chad, that's listed there.
Yes.
They do have a parent-to-parent training support virtually if you don't have someone maybe in your area that you can access to get resources and services on parent training. So just wanted to mention that one specifically too.
And I did put my information. If you have questions, you can certainly contact me. I have an Instagram handle, Peds Health. So I put that in the chat. You're welcome to look at I'm with Associates in Pediatrics. So it's aipdocs.com. You can certainly look at our website and reach out to me that way as well. And I have not had a chance. I don't know if there's any questions in the chat that we want to touch upon real quick.
I think we touched most of them. I think if I were to summarize them, I think, I just lost it. Hold on. A lot of people were asking about, meds and for SM and ADHD. And so I think what I was saying earlier, for both diagnoses, especially when you have both, I always ask myself the same question, and I literally will ask parents this, like, who do you see, who is your child at home, and what do they need? What supports what literal crutches would they need to be able to be themselves, like their true self, more hours of the day? And if behavioral is not enough, let's add to that. But I do think that it is a very dynamic thing to look at, and it's not a decision for medication that any parent takes lightly. If a parent is jumping to that, it's because they've been struggling, and they are not jumping.
Yeah. And I will say the medication for anxiety is a little different than the medicine, obviously, that we use for ADHD. And it is a question I get often because we see that overlap so much. Which one do we treat first? And so I will never start a child on more than one medicine at a time because you really need to see how it helps. And a lot of times what we find is that our kiddos who do have ADHD, the anxiety stems oftentimes because they are aware of those limitations that they have. So if we do start to treat their ADHD, oftentimes the anxiety is, mild enough where they can maybe get just the right amount of therapy and work through that.
Or
But I do have kids who are on two different meds too. So we do it stepwise. It's always my motto with medicine is start low and go slow. And that's, whether it's a SSRI that I'm using for anxiety or a stimulant that I'm using for ADHD. So
guys, unfortunately, there is something called too much of everything. And so you put too much of a medicine and then the everything kind of gets jolted. And so it can be very tricky. We could talk about this all day long and more, obviously. The other thing I just wanted to finish with, but if you guys have last things you want to say, is just that I think as parents, for you guys that are watching, I will always preach values. Your values around medication and behavioral health care matter a lot. So talk to your clinicians about it and say, like, this is how I'm feeling about it. This is how I've thought about it. Let them teach you. But remember that your values will always trump science and they matter so, so, so deeply. So as you are learning, just remember that. And there was one resource that I wanted to add, that if for kids under the age of 7 who have ADHD or oppositional defiant disorder, go to PCIT.org. PCIT.org is the treatment that PCIT-SM comes from. It's incredibly powerful treatment. The effect sizes, which just means how helpful and impactful it is, are so incredibly high because it's all in parent training format. So if you have younger kids, even if you have some of that ADHD and SM, I would recommend starting generally with PCIT, and some of the SM will start to resolve because the skills are the same. And their PCIT.org has a very long list of providers to help you. And also those providers are all going to be behaviorally trained. So they're going to know a lot of the stuff that we're talking about. So if you don't need that, I would still go to that list of providers because they're kind of vetted already for you. Same with the SMA website if you're looking for providers. Those are two hubs that I think are very, very strong at sort of pre-filtering for parents who there's no reason why you would know where to go. Do you guys have anything you guys want to end with today?
So appreciate you all sticking around for some extra time. Thank you for being such an attentive audience and for your questions. So such a joy to get to talk about this topic with you today.
Thank you guys so much. All right.
Thank you.